Do you ever get frustrated when a patient comes back after you've already treated them for the rotator cuff condition?
Now and then. Unfortunately, this is one of the toughest things we see, and it's also one of the most common things we see, that 4.5 million doctor visits each year for the rotator cuff. Well, today, Dr. Steele and I are going to share some tips that we have for assessing and managing the rotator cuff. We'll give you the most specific and sensitive tests. We'll give you the best treatments that we know of, and the home exercises, the recipes that we can give our patients to help them get better more quickly. We know that the shoulder dysfunction continuum is not something that starts with rotator cuff tears or ruptures. We know that in order to have a tear, you first had to have scapular dyskinesis and impingement. In fact, 95% of our patients who have a rotator cuff tear had impingement. The other 5 happened traumatically. And Dr. Charles Neer told us that those patients who have impingement, 100% of them have scapular dyskinesis, which means one or more of the shoulder muscles isn't working properly. There are 3 big groups of muscles that move the shoulder. We're all aware of the large movers, things like the deltoid and the pec and the lat. Those muscles rarely fail, and what they do is they elevate the arm, the glenohumeral joint, but in that process, they're often driving the humeral head upward. So you have a hard humeral head and a hard acromion on top, and some squishy stuff in the middle that doesn't like that upward force. So the second group of muscles, the rotator cuff, which yes, they generate torque, but their second job is to depress and retract the humeral head, to move that humeral head down from the acromion and back into the shallow glenoid. If they're not working, the rotator cuff is, the humeral head is allowed to ride up, and now there are issues. And then the third group of muscles that have to play a role are the scapular stabilizers. So we're aware of the big muscles like the trapezius, but we often forget about these other muscles like the serratus anterior, which attach onto the medial border of the scapula. And we forget about the lower trapezius, which holds that scapula against the thorax. Because the scapula, like this foam model here, where we have the coracoid out front and the spine of the scapula in the back, the muscles that primarily act upon it are the muscles that attach to the coracoid, which would be the short head of the biceps, as well as the pec minor. So if those are bungee cords, they're pulling that coracoid forward. And we need to counteract that force with the bungee cords called the serratus anterior and the lower trapezius, which hold that against the thorax. If any one of those 17 groups of muscles doesn't function, one of those 17 muscles doesn't function, it's like a concert where one of the instruments is not playing correctly. Something's going to pay a price.
I thought I would never use this model. However, this model is important because of one thing, is that we're going to exploit this joint today. This is a movement-related problem, so this is not usually a chemical-mediated pathology. That if we can actually modify the position and the function of the shoulder, we can have a dramatic impact on someone's pain. People don't walk around with pain all the time in their shoulder. It's a specific movement, it's a specific activity, and if we could really modify this, if we can change the position or the function of the scapula, we can have a dramatic impact on their pain day one. And that's how we build patient compliance and adherence to our treatment plans, is when we can modify their pain on the same day, hopefully meeting their treatment goals. Because unfortunately, with that hard bone right here, which is a ball, a humeral head, it goes onto a very flat surface of the coracoid. There's bad stuff that happens there. And when that hard bone starts to knock up into this bone, there's squishy stuff in the middle. We can be lazy and call it everything bursitis. However, the most common actual issue is impingement of that supraspinatus. And if you create compression there over and over again with your overhead activities, if you sleep on your shoulder, you're creating compression, or you're sleeping with your arm underneath the pillow, like we've all done several times after seeing many patients on a certain week.
Or boring instructors.
That pain is going to get worse. It's going to create ischemia there, and it's going to create inflammation and result in pain. So we really need to make sure that we're addressing all those things, and we start to hear those things like nighttime pain, like overhead activity, that we're able to kind of migrate these people over into this bucket.
So what are we going to do to assess a patient who might have impingement? How do we know if that scapular dyskinesis and impingement even matter?
Most of the time they're going to tell us. They're going to tell us their dysfunction. It hurts when I fasten my bra. It hurts when I tuck in my shirt. That's that lack of interrotation. But the most common thing that I hear is painful arc. They pick their arm up between 60 and 120 degrees and they start to feel pain. That's because they're starting to have some dyskinesis in the shoulder blade at that point. So we need to exploit that with their orthopedic evaluation. Any orthopedic evaluation done in isolation is worthless. However, when you can kind of couple a couple into a clinical prediction rule rule, now you can have a really good idea of what's going on. So in order to do the first test, the empty can test, what we're going to do is have the patient normally seated. In this case, we're going to be standing here for demonstration purposes, but the arm at 45 degrees in the scapular plane, and what I'm going to be doing is I'm going to be pushing down as the patient resists, looking for any kind of reproduction of chief complaint, normally your anterior lateral shoulder pain, or sometimes weakness, which we'll get into a little bit later. The second one is a passive test, which is Hawkins-Kennedy test. Once again, patient seated. I'm going to make this patient hurt a little bit more because I'm going to have them at 90 degrees flexion. I'm going to bring them into at least about 10 degrees of adduction and really create some impingement. I'm holding onto his shoulder. He's nice and relaxed here, and now I'm going to make him even worse by forcing a little bit of internal rotation. He's going to relax, be nice and passive, and he doesn't even want me doing that because he knows his shoulder is going to hurt a little bit. And then we can get into Neer's test, which is another passive test, and I'm going to have the patient he doesn't want me to do his right side because he knows it's going to hurt. And now he's once again nice and passive, full internal rotation, and I'm going to be bringing his arm up as high as I can, blocking his clavicle, not letting him cheat and bring his arm up and looking for reproduction of chief complaint. Those are great orthopedic tests. We're going to exploit that tissue, we're going to compress that tissue, we're going to stretch that tissue, and a lot of times we'll get reproduction of that patient's problem when they first came in. However, what I think and what the literature says is possibly a tad more telling of how this person is going to respond to our treatment and our rehabilitation are the next three tests: the scapular assistance, retraction, and repositioning test. So for the assistance test, I'm going to have, you know what, let's go ahead and sit for this one. So sitting, not sitting on a roller table or chair, but sitting is going to be very good because it's going to provide a nice firm base of support. Patient, when they bring their arm up in the scapular plane or in flexion, they're going to let me know when they have pain. Let's say it's right here at 90 degrees. I'm going to bring their arm down just to give you guys a better view. I am now going to be their serratus anterior, so I'm going to grab the inferior part of the scapula. As he picks his arm up, I'm going to be rocking his scapula up, and I'm helping him move that normal 2-to-1 ratio that the scapula and the glenohumeral joint have to do. And we're looking to increase that range of motion. If this helps improve the range of motion, I know this person needs some scapular motion in their life. Most notably us, as far as scapular mobility techniques and exercise that we can provide for them. The next one is a retraction test. A retraction test is showing, does this person need scapular stability in their life? So what I'm going to have to do is have the patient pick their arm up, and they bring it up to here, and it hurts. Now we're going to see if scapular stability will help them. And I'm just going to go here, just like better demonstration. I'm going to be providing an inferior medial line of drive. Once again, I'm holding his shoulder down here, but I'm not pushing down and blocking his motion. I'm going to create some compression and some inferior glide, and now we're going to see how high he can go, and what you can see is he can go a little bit higher. And I'm creating a good amount of force because I am now his lower trapezius and his serratus anterior in this situation. If this helps him, like it does for most of our younger patients who need more scapular stability, I'm going to move right into the scapular retraction test. Scapular retraction test is me teaching him how to do that same thing. So I'm going to say, Dr. B, you have a muscle between here and here. What I want you to do with about 10 to 15% of your force is just bring it down a little bit. And now I'm teaching him a little better scapular mechanics, still allowing him to move his scapula, but now when he holds that contraction, now pick up your arm, and we're looking to see if that range of motion can increase without me having to physically force that range of motion. Thank you very much. So 3 orthopedic tests to document scapular dyskinesis, 3 functional tests, and now we can move into what we're going to do about these patients.
So one of the things that we always want to differentiate is it functional, but also could it be coming from the cervical spine? I think that's why we had success with shoulder complaints in years that preceded the last decade. We were probably not treating the shoulder as well as we could, which we'll talk about in a second, but we were addressing a crucial component, and that's the cervical spine. So there have been a number of studies in the past year, and you and I have lots of years of experience that tell us the neck plays a role. In fact, a recent study said that 35% of patients who have shoulder impingement, meaning their humeral head is riding up, impacting the acromion, squishing the supraspinatus tendon, the subacromial bursa, 35% of those patients have an underlying nerve root irritation in the cervical spine. And the McKinsey Director of Research published a study last year that said about half of shoulder complaints actually originate from an asymptomatic cervical spine. So we're not just looking for those patients who have a radicular complaint that's very clear, it's shooting down their arm or their neck is very sore as well as their shoulder. We need to be suspicious of the cervical spine even when the neck isn't sore, when there isn't a loss of range of motion. And one of the tests that I like to use for that is something simple to differentiate, is the nerve root potentially irritated? It's a super simple test called the arm squeeze test, grasping that patient's arm and squeezing. If they have purely shoulder pathology, that shouldn't cause a problem, because although their symptoms are here, the problem's not here. It rides up into the subacromial space. But if that patient has an irritated cervical nerve root, now addressing that and compressing that nerve is going to provoke some symptoms. So the patient will say, ouch. When an arm squeeze test is positive, we need to be a lot more suspicious of the cervical spine. And not surprisingly, there's a lot of data that's saying nerve flossing and nerve release maneuvers make a big impact on our patients with rotator cuff pathology. And that's why, because half of them are actually being contributed to, if not being caused, by the neck itself.
One thing to think about to explain this to patients, sometimes they have a difficult way of looking at that is saying, listen, if you sprained your ankle, and when you sprain your ankle, just the skin above that is very sore. So just because the nerves are irritated, just because the structures below that are irritated, everything is irritated. So we can't forget about the nerves that control all those things. As far as the nerve flossing, I know that's something that some people may not have a lot of experience in. If you go right here to ChiroUp and you go clinical skills, you'll be able to go into the treatment techniques and be able to see all the treatment techniques, whether it's directional preference, whether it's instrument assisted, but you can actually go into, and let's just go and look at the median nerve floss, and you can type in and search and look at a median nerve floss, nerve releases, and you'll be able to see the treatment techniques on how to do each and every one of the nerve flosses that you can imagine for the upper and lower extremity.
You know, it's funny that even though we've been somewhat contributory to this whole project, I still use this resource to refresh me, because there are things that come up that you think, how does that go and what are the nuances of that skill? And so I use this on a regular basis myself just to refresh what do we need to do. One thing that I often don't forget to do is to make sure that we look at the spine. But the part of the spine that often gets overlooked is the cervicothoracic junction and the thoracic spine. That our patients with shoulder complaints will benefit usually from cervical manipulation, but we need to make sure we're addressing those lower levels as well.
One thing you can do with your patients is have them kind of have that protruded neck and super flex the upper thoracic spine, and have them pick up their arm. In fact, go ahead and do this with yourself right now. You're not going to go very far. Retract your chin, extend your upper thoracic spine, and now move. And it's amazing that range of motion that'll come back from the shoulder.
And actually increases that subacromial space, that mobilizing those areas to produce a natural version of that is something that actually gives us a little more space. And anything that makes that space bigger, whether it be functionally getting the acromion out of the way or things that we can do to functionally change the cervical spine, it's going to make a big difference in that patient's life.
So it really comes down to what can we do to get things moving, and then what we can have the patients do to keep things moving. There's some great exercises. They're all in ChiroUp, as far as the YTWL, having the patient bring up into a Y position and now bring it back, go down into the T position, bring the hands even further back, the W position with the elbows further back, and then L with the elbows at 90 degrees and bringing the hands further back, and really activating all those scapular stabilizers.
That's really a crucial one, because so many of our patients can't engage their scapular stabilizers. That when we ask them to do a low row or a seated row, the patient is going to use all arm movement. They'll use their triceps, they'll use some lats, and they're not using anything that we want them to. They're just learning bad mechanics. They're getting better at doing something bad. It's like Shaq practicing free throws. It's not going to change. So we need to make sure that patient's actually engaging the serratus anterior, engaging the lower trapezius, and the shoulder blades are moving. So the YTWL is one of those great exercises that we can actually make sure the patient is squeezing their shoulder blades together as they're coming through that process.
The next exercise is the corner pec stretch. Is one of my favorite exercises for this and other shoulder problems like thoracic outlet syndrome, but helping open up the pec minor and the pec major. This is a great way to do it on both sides. A lot of patients don't like going into internal rotation, so we want to be nice to them. We want to force them in there with a sleeper stretch. Something like this exercise for glenohumeral internal rotation, gently pulling the arm. If they're not able to do that, that's okay. Get a broomstick or something where they can hold on to it with two ends and slowly work into some internal rotation. It'll help them regain that range of motion. in between treatment visits. Those are the most important times. We see our patients only a couple minutes a day. We need them doing things on a regular basis to help improve that range of motion when we're not seeing them.
Which is one of the key things that's lost, that somebody who has impingement is almost always going to have limited internal rotation, and that's one of the tests that we'll use to measure how they're doing. How far can they bring their arm up their back, so we can see, are the exercises making a difference? They'll have the limited internal rotation and they'll have the painful arc, two classic signs of impingement. Sometimes these patients really don't like to move their arm up, which puts them at a high risk for developing a frozen shoulder, especially if they're a diabetic, 6 times greater risk of developing a frozen shoulder. Once they get into that, there are 18 months of dysfunction. So when the patient has pain moving their arm above 90 degrees, one exercise that we can use to help maintain that is the Codman pendulum, having them bend forward, making a circle in a clockwise and then a counterclockwise direction 25 times each time, and trying to make a progressively bigger circle. This helps to get them into a position that they otherwise wouldn't, but it also helps to just perfuse that rotator cuff tendon a little bit, which we'll see in a couple of minutes is one of the keys to the patient recovering.
And keep in mind with the Codman pendulum, that can be done active and passive. There is research on both of that. One, you can let the body kind of let the arm be dangling with the weight, but also be done passively to help, like you said, improve a little blood flow. The last couple are the low row, and like Dr. Berlesman said, this is one that is done wrong almost every single time. We're just using glenohumeral range of motion. Make sure when they're doing this, they're actually bringing the shoulder blades back and letting the shoulder blades go through protraction as they're letting that band go. And the same with Brugger with the band. The Brugger with the band almost forces this range of motion because when you do have supinated hands, it is going to activate those scapular stabilizers, like the straightest anterior more, and now bringing it behind your back with the elbows long and extended will force a little more scapular stability. If you want some more information on this, once again, go to the clinical skill sections. You can look at all of our exercises. I think we're up near 1,000 exercises, and look at each and every single one of the exercises. If you're not sure, like corner pec stretch, you can search by region, you can search by name, and you can click on here. Keep in mind these exercises are the ones that we provide in ChiroUp. There's also the ability to customize. So you can go in here, and if you want to call it something else, call it something else. If you want to change the sets and the reps, you can do that. If you want to create a new video, you want to create a new picture, you can do that also. Just make sure you save it, otherwise all your work will be wasted. But you can do this in your version, and then you can also ship this off to your actual clinic. It's a great way to customize ChiroUp for exactly what you need it for.
That is a huge point, because we all have recipes and we all have our favorite recipes, and while we've done some homework to define a recipe that works, we know that you have better recipes. We know that there's a lot more knowledge on that side of the camera than there is on this side of the camera. So we want to learn from you as well, and when you customize, we're able to see how does that work for a patient, and then we can share those best practices with each other so that together we really can become that best choice for our patients. One thing that patients don't want to choose is a rotator cuff problem. So once they start to have a cuff tear or rotator cuff rupture, now they're definitely going to have symptoms, whereas scapular dyskinesis can be asymptomatic. That 76% of healthy college athletes have some sort of dyskinesis. It just means the rubber bands on the pec and that attach to the coracoid, the pec and the bicep are too tight, and the serratus and the lower trapezius are too weak. That can be because they've developed a muscle too much, like that healthy college athlete. But when that happens and you start to irritate the tendon over a prolonged period of time, we used to think the tendon became inflamed. And so our initial model was that when you insulted the tendon, there was inflammation and it healed, and then it became inflamed and healed, and back and forth. Well, what we've learned is that's really not what happens. That histologic evaluations have shown us that once a tendon is irritated for more than about 72 hours, those acute signs of inflammation fade and eventually disappear. So rather than the tendon being red and puffy and swollen as an itis, it's actually turning to beef jerky as an apathy. It starts to become this disorganized mess of fibrous scar tissue where it's enlarging because it's so disorganized. Instead of the ropes of a bundle of fibers of rope or a telephone cable, it's now this mess of cables. And so it's enlarging and it's dysfunctional and it's weak. And let's not forget that that turns into a cycle, that tendinopathy, the failed healing response, is affecting the tendon fibers, making them weaker. And the tendon that we're talking about that's getting weaker is the supraspinatus. Well, the supraspinatus job as one of the 4 rotator cuff is to depress and retract the humeral head. So when it's not able to do that, now it's riding up. And when you have a thicker tendon, there's less space in general. So this cycle continues on in an apathy, where we've chased away the inflammation because of the repetitive insult, and we're not going to have any benefit until we invite some inflammation back into that process. That years ago, our treatments for rotator cuff tendinopathy were based on the ITIS model, that somebody came in with 6 months of pain in their shoulder or their medial epicondyle, lateral epicondyle, patella, Achilles. And we did everything to suppress inflammation. We used ice and we used ultrasound. If we really hated them, we put them in a sling. And those things didn't work. I can tell you that they didn't work. The only way they worked is if it was coming from the cervical or thoracic spine and our manipulation helped. What we now recognize is that those patients with a chronic problem, not a first injury or the first couple of days, but with a chronic tendinopathy, benefit much more by stimulating a controlled inflammatory reaction. So now all of our treatments, from laser or shockwave therapy, from taking a dull screwdriver and rubbing it over the top, or giving them the toughest type of exercise, eccentric, that's what works. So that's where our management is headed toward. But before we can manage them, we need to know, is the rotator cuff potentially torn? So how do we do that?
Well, first looking for weakness, and we're talking about a lot of the mechanical aspects of what happened, but we have to remember the neurophysiological aspects, is that when somebody does have an inflammatory process because they keep on doing the same activity over and over again, or they keep on having pain because of the same activity, whether it's a job or a sport, they're going to start to develop different patterns. So we need to, one, address that, but two, taking an isolated approach when we do have a weakness can go a long way in building patient trust and building a little bit of rapport with that patient to let them know we know exactly what's going on without going into advanced imaging. We have several tests that can do that. We're going to show two right now. We can take a seat right here. First are the external rotation lag sign. So the external rotation lag sign is taking advantage of the most common rotator cuff tear is going to be the supraspinatus, which is right in the front. However, the second most common is the interval between the supraspinatus and the infraspinatus, which is an external rotation moment as far as the rotator cuff, or depending on where you live, it could be the rotary cuff. So what you're going to do is have the patient nice and relaxed, and now I'm going to bring them through 20 degrees of abduction, full external rotations. I'm holding his elbow here and I'm really making him externally rotate.
That's full.
Yeah, is that it? You know, a little more? And I'm going to make him hold it right here. So I'm going to let go of my hand and you're going to hold that position and he's going to hold it right there. I am maximally activating those muscles. If he had a tear in there, if he had some tendinosis in there, he's not going to enjoy that very much. If he did have that, he would do this and he'd retreat. He'd be like, that hurts, and that'd be a positive sign for a tear within that interval or the infraspinatus. The next one that just came out in 2020 was the Dyne test. I love this test because this tests the different arcs of motion in the most common muscle that's going to be torn, which is that supraspinatus. So we can have the patient move in two different ranges of motion, and they're going to throw in some overpressure. So first on the scapular plane, he's going to bring his arm up as high as possible actively and back down, and we're going to look for any kind of pain or problems. However, the goal in this test is really when he brings his arm up, and now I'm going to be pushing down and he's going to be resisting, and we're looking for different arcs or different ranges of motion that it's painful or most commonly weakness. We can also have him move through full abduction as high as he can and back down, looking for any kind of pain or weakness. Once we're able to do that actively, now I'm going to add in a little bit of overpressure and really jam it down there for him. No. So those are two great tests to look for any kind of impingement type syndromes, or in this case, a weakness syndrome with a tendinosis or a tear. We're very good at identifying these even before we see them. So a lot of patients will show their hand just by knowing their age, by looking for any kind of a weakness with these orthopedic tests, and looking for weakness in abduction, flexion, or external rotation like the test that we just saw. This is by Bartolozzi, and I forgot the year. However, if we're able to look at these positive signs as far as a rotator cuff tear, we know what we should be looking for. I'm probably not going to start my evaluation with scapular dyskinesis, although it may end there. It's going to start with looking for signs of a rotator cuff tear.
So once we see that, there are definitely things that we can do to address it. One of the things that we'll do is assess the muscles themselves to say which muscle is involved and what do we want to do to that muscle. Will be most suspect of tears in the four rotator cuff muscles, the infraspinatus or the teres, which are both external rotators. And you can see from these videos that trigger points develop in those muscles. We can strip those out. We're not going to play each of these videos now, but we're going to give you a resource that you can access these videos. So we'll look at the infraspinatus and we'll also look at this guy, the subscapularis. one of the most overlooked muscles in the body that oftentimes our patients with lingering shoulder dysfunction, where we've tried everything and they're not better, maybe we miss something in the subscapularis. We'll also take a look at the supraspinatus, that while the tendon is the focus of our energy, that's where the pathology is occurring, certainly that muscle gets overworked with dysfunction and trigger points. And finally, probably the least active of the 4 rotator cuff muscles as far as pathology, the teres minor, but if we need to work that out, that's one that we often forget as well. As far as the management, the good news is we're going to do much of the same thing. So once we understand the recipe for scapular dyskinesis, since that's typically the foundation in 95% of cases, that's what we're going to address in order to help change that patient's mechanics. So a lot of the same exercises that we prescribe for impingement are going to be the same exercises that we prescribe for rotator cuff pathology. So that's the YTWL, the corner pectoral stretch to loosen up the bungee cords that are too tight attaching to the coracoid, glenohumeral internal rotation, which is almost always lost, getting the Codman pendulum, especially in acute cases or those patients with nighttime pain. We could consider doing some stability exercises like the low row and the Brugger with the band, but the part of the recipe that actually changes once a patient has a shoulder impingement that's gone on to rotator cuff pathology are performing some eccentric exercises.
The eccentric exercises should be done safely. There's a lot of really good exercises. In fact, the Kibler exercises are phenomenal. There's a ton of research on that. We really try to choose safe, effective exercises for our patients that they're not going to make things worse, because they are going to make things worse. That's the point of eccentric exercises. They're going to expect pain between a 3 and 4 out of 10 with doing these exercises. So I want to keep it safe for them. The first one is the eccentric scapular stabilizers from a side lying position, having them slowly move into shoulder flexion. Now, this is often difficult for patients to see. In fact, if I looked at this picture, I could get an idea of what's going on, but let me show you what that looks like, what the patient's going to see. So instead, you can go right over here to clinical skills. You can go into your exercises, and you can actually search for all the different exercises. In fact, if you just look at all the eccentric exercises, it'll pull them up here, and you can see them all, but we're going to look at the scapular stabilizers right here. And now on an app form with this healthcom.io, this is what your patient's going to see. So they're going to get an audio and video demonstration.
Stabilizers. There's that annoying voice again.
So they're going to be able to see exactly what's going on with each exercise and make it easy for them to understand which muscles they should be affecting. They can do that for the external rotators and also for the supraspinatus. It is important with any building exercise where we're progressively loading somebody. Remember, stretching is loading someone. But we go to resistance, you go to weight, you go to eccentric, we're progressively loading that tissue to build up the capacity of that tissue to prevent re-injury. We really need to start a very safe, very low load, and then work up to higher loads. This is a slow process. I tell my patients I'm not trying to offend them with these remedial exercises, but they are necessary in the rotator cuff. These are small muscles, and they require a delicate set of initial exercises.
And a delicate balance, because we are trying to create some therapeutic damage, that if the patient has a beef jerky tendon and we've chased away inflammation, or the body has chased it away, we're inviting it back, and nobody likes inflammation invited back, at least in the short run. So as you said, a little bit of discomfort, a 3 to 4 and a 0 to 10 scale is acceptable. We just want to make sure we don't overdo it. So we want to start with a moderate level and then advance that. And the one clinical tip that I use to figure out have I gone too much is if the patient says, here's my new range of motion in the arm, you've definitely gone too much. Or number 2, if they have nighttime pain. That if the patient says, you know, my nighttime discomfort was provoked again, that's a patient that we need to take down one step. And also take a look at how they're sleeping. Because this is an ischemic problem, that there's a lack of blood supply to that tendon. First of all, our heart's not beating as hard at night, so it's not pumping as much blood. If we lie on that side, that's provocative because we're compressing it. And if we lie on the opposite side and let that arm traction across our body, that's provocative because we're creating a tension ischemia. So having that patient lie on the good side with a pillow underneath their arm sometimes helps that nighttime pain. The other thing that helps is making sure that patient understands what's wrong with them, what you're going to do, what they can do to help themselves, and exactly how to perform their exercises. So one thing that we do is we prescribe condition reports to all of our patients. And for me, it takes this long. Debbie, can you prescribe a condition report for Dr. Steele? And at that point in time, I know that she's going to prescribe the condition report for whatever condition I told her. My patient's going to get a version that they can use at home. So Dr. Steele is going to give us a quick demo here of how that works.
So from here, I put in the patient's name, I put in the region and the actual diagnosis. It's going to pre-populate based on what the evidence says I should be doing for treatments, also for ADL information and their exercises. I can change all this. I can add stuff, I can take away stuff. And remember, all your ADLs not only have a written description, but also a video description. I can change my treatment plan, and these are all preferences. So if there's a treatment plan that you normally use, a goal you normally use, it's going to go ahead and do that. At the time of creation of this patient, it's also going to put in their primary care doctor. Let's go ahead and create an MD initial report so we can have good communication with other doctors in our area. I can print this, I can email this, or I can actually do both. And quickly I can provide my patients with this. The patients are now able to see and read exactly what's going on with them as far as their diagnosis in 6th grade language of their condition. They're also going to see what we're going to do for them. Remember, each and every one of these things, if you do a factor technique, if you do ART, if you do a certain patented technique, you can enter that information into here as far as the things that you do and you're certified to do in your practice that makes you special. These are all things that help the patient understand why you're the best solution for them. It's going to also put in their treatment plan. It's going to include the ADL information, and then also at the very end give them their rehabilitation exercises so they can once again look at the pictures and the videos. They can log into an app and see all their exercises. This is a simple way to do two things. One, help you. It's going to save you time. And the second part is going to help your patients get better faster. If we can help more patients get out of pain and understand their condition just as well as we do, we're going to have a group of promoters in our community to help build our practice.
Yeah, that knowledgeable patient who knows what's wrong is an empowered patient. So they're a more compliant patient. They're more likely to give you good reviews. You're more likely to get good outcomes to get those good reviews. But one of the things that I really like, in addition to not having to go through the exercise 5 times, you always know if a patient tried their exercises, they ask you how to do them. Well, ChiroUp helps to solve that because you're able to deliver the patient, give them videos that they can watch in their living room, and it answers a lot of those questions. It cuts down on exercise questions by 90%. The other thing that I like is that it helps to build my practice, because 30 days after I send this survey, the patient gets a survey saying, how many times were you seen? What's your overall level of satisfaction? How much better are you? How likely are you to refer to this provider in the future? If they rate you as a 9 or a 10, they automatically are taken to Google or Healthgrades to rate me online. So when you Google our office in the area, there's 100 options and we're at the top, not because we're the best, but because we have a lot of reviews that push that SEO up. So I like it for the time-saving process. I love it for the way that it helps to build my practice, and most importantly, help that patient achieve their goal, which we're all out for in the first place. If that's something that you think you'd like to check out, the good news is you can try it 14 days, no cost and no commitment, and we never have any credit cards. ChiroUp will provide you with all of those resources. You can check out the exercise demos. You can prescribe reports to patients. You can even use and implement our marketing plans. I invite you to try that for 14 days. There's no cost. Just visit chiroup.com, click on the free trial button, and get started. If you have any questions, we're happy to help. I'm Tim at chiroup.com, Brandon at chiroup.com, and our team will be in touch with you. We appreciate you spending this half hour with us. We hope that we've been able to provide something that's useful for your practice, and we hope that together we can really become that undeniable best choice for patients and payers alike. Thanks for watching.
Thanks.